The following episode is brought to you by the American Urological Association. The American Urological Association is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. For more information on how to claim CME credit or to view faculty disclosures, please visit the AUA University at auanet.org/university. Support for this episode has been provided by independent educational grants from Lantheus Medical Imaging and Novartis Pharmaceuticals Corporation.
Good afternoon. My name is Jay Rahman, and I am professor of urology at Penn State Health and chair of the AUA's Office of Education. It's my pleasure to host another episode in our educational podcast series with this specific episode titled Biomarkers and Molecular Imaging for Prostate Cancer. It's really my pleasure to announce my guest today, Dr. Simpa Salami. He is a fellowship-trained, board-certified urologic oncologist, as well as associate professor of urology at the University of Michigan. His clinical expertise is minimally invasive surgical treatment of prostate and kidney cancer, and his laboratory does focus on developing novel cancer biomarkers to improve tumor heterogeneity, to overcome tumor heterogeneity and multifocality, and really to determine the optimal means of risk stratification for urologic cancers. It's also our pleasure. Dr. Salami is a recent winner of the AUA's Gold Cystoscope Award. And obviously, first of all, congratulations on that tremendous accomplishment. And in turn, really our pleasure to get 30 minutes of your time to talk to you about these topics.
Thanks, Dr. Rahman. This is really my pleasure. It's great to be here with you today and to go over this very important topic.
So, Simpa, maybe you could just, before we dive into it, give our listeners a little bit of a sense, maybe at a high level, of what we're going to be talking about over the next half hour. And then, of course, we'll dive into some of these topics in greater detail.
The goal today is really to see how we can leverage the tools we have available to improve early detection and risk stratification of prostate cancer using advanced imaging techniques like PET, MRI, and novel radiotracers. We'll also discuss how these tools can improve the accuracy of prostate cancer diagnosis, staging, and treatment monitoring. And of course, we'll dive into the biomarkers that we have available, diagnostic, prognostic, and predictive biomarkers.
So I think I'm going to maybe start with that last point that you just made. And, the title of this episode is really Biomarkers and Molecular Imaging. So we'll start maybe talking a little bit about biomarkers. And, that's a very broad term, right? I think you just kind of alluded to it. It's a broad term, and maybe just walk us through a little bit. What are biomarkers? And then maybe what are the different settings that we use them in? Because obviously they can be used in different settings, as you alluded to. So just walk us through that as a starting point.
A biomarker really is any molecule that can be a sign of a normal or an abnormal process like cancer. Any molecule like DNA molecule, RNA, or protein, or microRNA. And these biomarkers can be in body fluids like blood or urine. It can be detected in tissue, such as a biopsy tissue. And the goal is to use these biomarkers in various settings. They could be used for as a diagnostic test. They could be used for a prognosis, meaning a biomarker that can tell you if a patient will do well or not, a patient that is likely to die from a disease versus not, or a biomarker can tell you if a patient is likely to develop metastasis or not. And then there are biomarkers that can predict who will respond or be resistant to a specific treatment. So there are a variety of biomarkers, and as I mentioned, each one has its own place in the entire algorithm for early detection of prostate cancer.
So let's talk a little bit then about early detection. Obviously, you were on the early detection guidelines panel for the AUA. So, we're not only going to pick into your expertise with regards to biomarkers, but obviously your expertise as being on the guideline. But talk to us a little bit when we're talking about early detection of prostate cancer, and we're talking about biomarkers, maybe start with, what is the most simple biomarker that we've been using for maybe 30 plus years, and then maybe walk us through some of, where we have beyond that sort of very basic biomarker.
PSA is really the most widely used oncology biomarker, as you alluded to, and it's still a good screening test for prostate cancer early detection. I think, despite the controversy surrounding the use of PSA for screening and early detection, it is a very good biomarker. I think what we just need to do is to be able to screen smarter, interpret PSA results, well, as we evaluate patients who are at risk for prostate cancer. For example, as part of the AUA guidelines, we recommend repeating a PSA blood test that is elevated, because PSA can be transiently elevated in various benign processes like BPH or transient inflammation or infection or urinary retention. So we recommend repeating, PSA blood test if it's found to be elevated within a month or two, and if it's still persistently elevated, you would then proceed to evaluate the patient, further. Now, to supplement the performance of PSA, we have a variety of serum, urine, and tissue-based biomarkers that can be used to further risk stratify patients. For example, in blood, we have tests like ISO-PSA, the PHI score, 4K score, and yet to be FDA approved are Stockholm 3 and Proclaris. And then in urine, we have tests like SelectMDS, ExosDS, MyProstate score. And then in tissue-based space, we have Confirm MDX. This test can be used to supplement the decision to proceed with a biopsy or a repeat prostate biopsy.
So a few questions in this realm, and I realize some of this may be your own thoughts. So I know that in some of these podcasts, I'm asking you your opinion, not so much as speaking on behalf of the guidelines panel, but maybe just asking your opinion. I think you highlighted one of the really important concepts, which is simply repeating a PSA value. And I think this is true when you look at almost any disease state, right? Nobody's hypertensive after a single blood pressure reading that's elevated. Nobody's diabetic because they had a single glucose level that was elevated. So it's very intuitive. And so the first question I'd ask you is, you sort of alluded to it, timeline. So if we're going to repeat a PSA for a confirmatory test, what's a broad timeline that you use in your practice?
Generally, I would say a month or 2 months should be sufficient if this was due to a transient elevation. For example, let's say a patient has a UTI and then you treat the UTI. I'll follow up, a month or 2 afterwards with a repeat PSA test. That should be sufficient if this is transient or not.
And then maybe my second, maybe practical question for you is, when we look at PSA, there are different ways that we can use PSA values. Obviously, the one that I think is most readily available is simply looking at like the free and the total percentage. So is that a tool that you use at all when you have a PSA elevation? And let's say you're bringing somebody back 8 weeks thereafter. Do you use at all the free and the total to not only get another PSA reading, but maybe also to get some information based upon that ratio of the potential to investigate this further? How do you use that?
That's a great point. It is a tool that I do use, actually, as a matter of fact, when I'm repeating the PSA. However, the percent PSA has been shown to be of value when your PSA is within the range of 4 to 10. So if a patient has a PSA of more than 10, for example, I generally will not repeat the percent free PSA because it is unlikely to add any value. And to follow up on that, I think the other parameter that I often use in my practice, especially if a patient already has imaging or a previous biopsy, is PSA density, right? It's like, just calculating the ratio of the PSA to the prostate size. And in general, a PSA density of more than 0.25 or 0.3 is associated with, prostate cancer. And in general, if PSA density is less than 0.15 or 0.10, the likelihood that that patient has a high-grade prostate cancer is very low.
No, that's great. That's a great point, especially if you have some sort of imaging that you can use to a rough volumetric calculation. I think your point is excellent about being able to get that PSA density information. So I think one of the things that's always a challenge is you mentioned that when we look at serum biomarkers, there are several. When you look at urine biomarkers, there are several. And tissue-based obviously is maybe in the post-biopsy setting, but how do we not get overwhelmed? Because they all, I'm sure, have some type of proprietary algorithm associated with them. And I can imagine that it may be sort of an overwhelming prospect as you're looking at your individual practice and you're trying to decide which one of these should I incorporate. Do you have, and I'm not asking for specific names, but do you have some sort of advice on, do you like to use a blood-based biomarker to correlate a PSA? Do you like to use urine because maybe it's a different medium? Just broad philosophies on how to navigate the array of biomarkers we have available.
Yes, perhaps I can give a broad overview of the general performance of these biomarkers.
Sure.
That we mentioned. In general, they tend to decrease the need for biopsy by about 20 to 30%, and they tend to minimize the detection of grade group 1 prostate cancer. And in general, they capture nearly all men with grade group 2 or above, prostate cancer. Based on the data, the performance are actually very, very similar. So when I look at these different biomarkers, I generally, go with the one that I'm comfortable with, or the one that I think has the most robust, data, because these biomarkers may perform differently in different patient populations. So I want to make sure that the population that the biomarker has been evaluated in is representative of the population of patients that I'm treating. But philosophically, I know that we haven't really done a robust job of comparing serum to urine-based biomarkers. But to your question, my hypothesis is that a urine-based biomarker has the potential to do maybe better than a blood-based biomarker, just because I think it will capture what is happening in the entire prostate, especially when the urine is collected after an attentive DRE or prostate massage.
And then I think the last point, I think, as you alluded to, is that as we think about biomarkers in general, urine or blood, we need to be a little bit cognizant about the setting that we are looking at, right? So I'm sure that maybe your algorithm, for example, in the initial evaluation setting, when you're trying to determine the value or need for a biopsy, may be different in that person who's perhaps had a negative biopsy, and you're trying to do an assessment of, do I have enough convincing evidence that this person should undergo a repeat biopsy? Is that an accurate statement?
Absolutely. That's an accurate statement. So in my practice, for example, I do not routinely order a biomarker test reflexively. I order a biomarker test if I think it's going to change what I do in the evaluation of a patient. So, for example, a patient has had a negative biopsy and PSA continues to rise, MRI doesn't show a lesion, and I'm worried, what am I missing here? Before I subject that patient to an additional biopsy, I will order a biomarker test, and only if that test result indicates that the patient may harbor high-grade cancer will I proceed with a follow-up a repeat biopsy.
So we've talked a little bit about biomarkers, and I would say what perhaps is even more ubiquitous, and I might be wrong, but I do feel that in the past, 6 or 7 years since those first Sentinel papers came out regarding MRI and fusion technology, I feel like MRI has really exploded. And at least in my practice, it's hard for me to think of patients that have not been referred in who've already had perhaps an MRI or some type of imaging. So maybe talk a little bit about that. And then I'm going to ask you the maybe difficult question of how you integrate imaging and biomarkers into the whole algorithm. But let's talk about imaging first, MRI, maybe some thoughts on that.
I think MRI has been one of the greatest introduction to clinical practice when it comes to early detection of prostate cancer. Because if you think about it, before we started using MRI routinely for early detection of prostate cancer, we would do systematic, prostate biopsy guided by ultrasound, and essentially we're just, passing the needle through the prostate, hoping that somehow it would pick up the cancer. And prostate cancer really is the only cancer that, or the prostate is the only organ that will biopsy without knowing where the cancer is until MRI. So MRI really has been revolutionary in the way that we detect high-grade prostate cancer. And like you, I use it routinely in my practice in both the initial and repeat biopsy setting, because I think that just having an idea where a lesion is and targeting it. Of course, there are false positives. We know that, and patients with negative MRI too. Some of them, up to 10 to 15% may harbor high-grade prostate cancer. Despite those limitations, I still think that MRI provides great value in early detection of prostate cancer.
Maybe a corollary to that is your thoughts a little bit on the potentially inevitable inter-observer variability. And you can make the same comment maybe on looking at grade group when pathologists are looking at small slivers of tissue and trying to make an assessment of group 1, group 2. I do think that one of the things we've learned a little bit more is perhaps it's valuable to look at your own data from your own institution, because at least at our place, our diagnostic accuracy for clinically significant prostate cancer was much lower than what was published in some of the early sentinel trials. And that was sort of eye-opening, that it was almost like an iterative feedback that maybe we have to refine, the definition of these. Maybe your thoughts on sort of that question about, beauty being in the eye of the beholder and interpretation of the imaging.
I agree with you 100%. I think certainly it's important that everyone looks at the institutional data to see what the cancer detection rate for each pirate's category is. What we have done at our institution, for example, very, very early on, is to have radiology, pathology, urology conference where we actually review cases that we think, for example, pirates 5 case lesions that after a biopsy comes back benign, to re-review it and then determine whether we need to repeat the biopsy or not. And very recently, we've also started doing MRI in-gantry biopsies for really highly suspicious lesions that comes back benign after a fusion biopsy. So I agree with you. I think it's important to know what the cancer detection rate is at our individual institution to determine the accuracy of our MRI, because certainly there's significant variability in inter-observer variability when it comes to MRI interpretation, and also the quality of the MRI images is also important.
So how do we put this together a little bit? So we've talked about biomarkers, we've talked about imaging, and I'll maybe ask you this question in the context of there may be only a finite amount of money that a patient is willing to undertake right out of the gate, right? Between PSA-based screening, biomarkers, imaging. How do you sort of put all these together? Is there an algorithm that you use? And I'm sure there may be differences in different people's practice, but I'd love to hear how you kind of put all this stuff together in the setting of early detection.
I'll start out by saying that there's definitely tremendous value in being able to combine the strengths of biomarkers with the strengths of MRI. The data currently is limited in terms of how to integrate both. For example, which one should you do first? Should you do a biomarker first before MRI, or MRI first before a biomarker? A recent study, the ProScreen trial, in that study, they evaluated 4K score before MRI. So if a patient comes in for screening, PSA is elevated above 3, they get a 4K score. It's only if the 4K score is more than 7.5%, we'll then proceed to get an MRI. And then if the MRI shows a lesion they will do a targeted biopsy. If the MRI does not show a lesion, they will only do a systematic biopsy if the PSA density is more than 0.15. So essentially, that study really minimized the number of biopsies that had to be done, and it also minimized the detection of grade group 1 prostate cancer. I think we need studies like that to evaluate all of the other different biomarkers that we have in clinical practice. And then to follow that will be an effectiveness, cost effectiveness, analysis to determine what should you do first. Should you do MRI or a biopsy first? Because one might argue that you do get a lot of information from MRI, and maybe you could, decrease the amount of money that you spend on the biomarkers because they are expensive as well. I think one advantage of doing biomarkers first is that maybe they're less laborious than MRI, potentially less, expensive than MRI, but we'll need a cost-effective analysis to determine what should be done first.
No, that's a great point. So if I understand, I think your take homes are that, and you cited that very nice study that the incremental use of both certainly has the value of potentially decreasing the number of biopsies that we do. Is that correct?
That is accurate.
But really, I think the what remains to be determined for all the points that you just outlined is if one were to incorporate both biomarkers and imaging, the order of which you perform these tests and how they would perhaps dictate your practice. Is that correct?
Correct. Yes.
Yeah, and it's interesting. I was just thinking as you were saying that, I think to myself, and I was thinking to myself, which one would I do first? And it is interesting. Sometimes you'll get some patients who come in with a PSA of, 8 or 9, and you get an MR on them, and they have 120 gram prostate, right? And then going back to that, one of those initial points that we made that you articulated, which is that person's PSA density is very low. And suddenly you say to yourself, wow, this person, the likelihood this is due to prostate cancer, especially if they don't have a visible lesion and they have a large prostate. So I think that you're right, that there's a lot to still be determined on sequencing of those. So let's kind of pivot a little bit. And we've been talking a lot about serum, urine, biomarkers sort of in the early detection screening setting. We've talked about MRI and it's how we can enhance and be an adjunct to improving our biopsies that we do. Let's talk about tissue-based biomarkers and really maybe biomarkers that may allow us to do risk stratification. Talk to us a little bit about what are those and what setting do we use those in? Maybe those two questions to start.
Several biomarkers are currently available for risk stratification after a diagnosis of prostate cancer. These are biomarker assays that are performed on the prostate cancer tissue. They include Decipher, Polaris, Oncotype, ProMark, and these different biomarkers measure a number of genes. For example, Decipher measures 22 genes, Polaris 31 genes, Oncotype is 17 genes, and they do provide prognostic information. So early on, we talked about prognostic biomarkers as tests that can tell you if a patient is likely to develop metastasis and when, if a patient is likely to die from prostate cancer and when. So they provide that kind of information. What they currently do not provide is predictive information. For example, who will respond to one treatment versus the other. For example, we cannot use these biomarkers to determine who should undergo surgery or radiation, for example. In the radiation space, Decipher has been shown to be able to determine who needs androgen deprivation therapy in addition to radiation in patients with intermediate risk prostate cancer. And there's some preliminary studies that also indicate that you could use Decipher to determine the duration of androgen deprivation therapy. A common place that people use these tissue-based biomarkers that they are not necessarily developed for is in determining whether a patient should go on active surveillance, especially patients with Gleason 6 prostate cancer or grade group 1 prostate cancer. And the reason why is these biomarkers do not necessarily do well in that space is because of the heterogeneity and multifocality of prostate cancer. So your biomarker test result is only as good as your biopsy.
Mm-hmm.
If you have a grade group 1 prostate cancer on biopsy, the biomarker score routinely will be low. If you have grade group 2, then it probably will give you a higher score.
Yeah, I think this point that you just made is so critical because I think a lot of it comes back to the point you made earlier, which is the importance of appropriate tissue sampling, right? Because all of these are just based on the tissue that you obtain. And so let's just hypothetically say that the index lesion is an anterior zone lesion that was never sampled, and you have peripheral zone lesions that are grade group 1 and 2, and you do the biomarker analysis. That may not accurately capture in any setting the true biology of the cancer that is most likely to be the dominant lesion in this patient. Is that sort of an accurate statement?
That is correct. And that's, because of the heterogeneity of, prostate cancer. So, you painted a scenario where you have two different foci. The same is also true when you have one focus of cancer that you equally have a lot of heterogeneity within the same focus. The biology of one region may not necessarily be representative of a different region of the tumor.
Now, we've talked about tissue-based biomarkers as it pertains to biopsy specimens. What about just maybe your brief thoughts on tissue-based biomarkers in these patients that have already gone through a radical prostatectomy, and they have a whole prostatectomy specimen? Are we using tissue-based biomarkers in that setting, and how are we potentially using that?
In the post-prostatectomy setting, tissue-based biomarkers could be used to determine who may benefit from adjuvant radiation therapy, and potentially who may benefit from radiation plus ADT in the post-prostatectomy setting. Beyond that, in terms of surveillance or how to monitor the patients after prostatectomy, they have not been shown to be useful at all.
Great. So maybe in the last few moments here, for the last few minutes, maybe I'd like to talk to you a little bit about imaging and using imaging for improved risk stratification, for improved staging. So, and certainly, I think the ones that come to mind, obviously, we've spoken a lot about MRI. I would say the quote unquote new kid on the block is PSMA-based PET imaging. Maybe talk a little bit about either or both of those, and then maybe any other tools that we have on the horizon just from an imaging perspective that can sort of enhance or improve what we can do for risk stratification of prostate cancer.
Sure, absolutely. So really briefly about MRI, it provides some local staging information. For example, in my practice, I sometimes use it to determine whether I can do nerve sparing versus non-nerve sparing surgery. But of course, there's also variability in the capacity of MRI to determine whether a patient has extraprostatic extension or extracapsular extension. So there's some limitations to that. In speaking about PSMA, I think PSMA PET scans are another great innovation in our ability to stage patients with prostate cancer after diagnosis. Before PSMA PET, we would use CT scan and traditional bone scans, and studies have shown that PSMA PET imaging targeting prostate-specific membrane antigen performs better than conventional imaging when it comes to staging for prostate cancer. So in patients with localized disease or high-risk prostate cancer, PSMA PET scan has been shown to provide 27% greater accuracy when compared to conventional imaging, for example. There are essentially two tracers currently that are being used, and that include F18 DCFPYL and gallium-68 PSMA-11 that are currently being used. On the horizon are a couple of other agents that have been developed. We have F18 PSMA 1007 and F18 Rho PSMA imaging that are currently undergoing development. However, studies have shown that the performance of the two that are currently clinically available are quite similar, with a specificity of more than 95%.
And what about artificial intelligence and any sort of radio guided surgery? Maybe can you briefly comment on either of those two?
Absolutely. So artificial intelligence is one great innovation of our time, right? It's been applied to a variety of things, right? It's like, making your task list every day or planning your vacation. And so in medicine, I think this is one area where I think artificial intelligence will be very, very useful, will be imaging, because there are a number of quantitative measures on imaging that may not be apparent to the human eye, and having a software that can leverage or extract those different measures in aggregate and provide accurate information, I think will be very, very helpful. So artificial intelligence is currently being used to help interpret, MRI. It's still being developed, I should say, to read MRI, to segment lesion as well as segment the entire prostate. And it's also being used to see if it will do better in identifying regions of metastasis or micrometastasis on imaging. And you can envision a situation where you use artificial intelligence to overlay your MRI or PSMA PET imaging to the pictures that are acquired during robotic surgery, and use that to guide your surgical resection, to identify regions of extraprostatic extension, to do nerve sparing surgery, and potentially even determine if you're getting a negative margin or not. So there's a lot of excitement in these different areas, and we're really looking forward to how this will change the way that we approach prostate surgery.
Well, it's super. Well, Simpa, I really want to thank you. It's been a true pleasure to get a chance to speak with you over the past half hour, pick your brain on a lot of practical elements that, truthfully, outside of the realm of urologic oncology, these are principles that I think apply to anybody, frankly, in urology. It's probably one of the most common diagnoses we see outside of hematuria is the elevated PSA conundrum and how to screen for prostate cancer. And I really very much appreciate your time and your expertise this afternoon.
Thanks, Jay. Much appreciated.
For our audience, for more information, please visit us at auanet.org/university. Dr. Slami has put in some nice references that will allow you to do some greater reading on any of the topics that we covered today. Simpa, again, have a great fall. Much appreciation for taking some time this afternoon.
Thank you.